Okay, educational, and will change your practice. We're going to talk about a patient, Tanika, who is a nurse, who presented to the emergency department 6 days post-strangulation. She came in with the chief complaint of domestic violence, and this is the actual quote from the emergency physician who saw her. 36-year-old female who had domestic violence in the past from strangulation from her husband, who was involved in a recurrent domestic assault last Thursday, 6 days prior to presentation. In that event, she has some memory, but it's somewhat cloudy, which is an important clue. Why are individuals who are strangled and have their hippocampus deprived of oxygen cloudy? It's because no blood flow to the hippocampus, no memory. And she's coming in or remembers him going for her throat. This is Tanika, and she has given permission for you to see her face and her medical record. This is such an important case. And as I said, Tanika is a nurse. This is a quote again from the emergency physician. She was seen by the prosecutors and domestic violence specialists of San Diego PD. She has bruising to the back of her right ear, the angle of the mandible on the right, and occasional small bruises to her chest. Apparently, the patient was told by her prosecutor that she should, quote, get an MRI. She does not have insurance, which should not enter the equation of treatment or non-treatment, but should be supported by the Victims of Domestic Violence Fund per her report. She has a number of areas of pain of all the sites of these bruises, no numbness, no tingling, no weakness, no nausea, no vomiting. Review of systems is negative. Past medical history is none, medications none, allergies, vomiting to erythromycin. Social history doesn't smoke except for one prior domestic violence strangulation 6 months ago on the second night of her marriage. Vitals are normal, neuro exam is normal. 5/5, everything, cerebellar function is intact. This is the contusion behind her right ear. Okay, now get your phones out and ready to text. So, what is your impression based upon that history? Is it A, potentially life-threatening strangulation, discussed with spine service and will send for stat CTA? Or B, contusions and status post-strangulation, will DC home to follow up with PMD and get outpatient MRI if needed, no ED imaging indicated, and then so text. Or C, minor contusions, will discharge home, follow up with PMD and DV detectives, no ED or outpatient imaging indicated. Okay, so text A, B, or C, 586, 587, or 588. Okay, and we'll go to our switch screens and we'll see what the answer is. Okay, well, predominantly looks like number A. Okay, let's go back and see where we go. Okay, the emergency physician's plan was number A. He discussed with the spine service, he said, I don't see any ligamentous instability, I do not think an MRI is indicated, but I will order a CTA. And after discussing that with spine, but he went ahead and said, I will presume all this will be negative because she looks like a peach 6 days out. If there was going to be a complication, I would have expected to have seen it by 6 days post-strangulation. So he writes his discharge plan, which is number 1, contusion, and 2, status post-strangulation, with a plan to discharge home if the CTA is negative and follow up with the spine service, assuming that everything is negative, until he gets that call from the radiologist. Now, before we get that call, let's see what is the imaging test of choice in a strangulation patient with either loss of consciousness, petechial hemorrhage, neck swelling, or neck contusion. So what is the imaging test of choice? Is it a CTA? Is it a CT of the C-spine with contrast? Is it an MRI of the neck? Is it Doppler ultrasound of the carotids? Or is it soft tissue neck AP and lateral? So the imaging test of choice in a strangulation patient who has any of those symptoms, strangulation with loss of consciousness, any petechial hemorrhage, any neck swelling, or any neck contusions. Okay? Okay, and we can switch to our answers. Okay. So it looks like it's between MRI, MRA, and CTA. Okay, with MRI, MRA. Now, the question is, how easy is an MRI, MRA to get at 2 o'clock in the morning? Okay. So here is the results of Tanika's CTA. Bilateral carotid, internal carotid dissections. Bilateral internal carotid dissections with a flap, intimal flap on the left. And she looks great. We've heard a lot about protocols. When do we get CTs? When do we get CTAs? And I'm here to tell you that based upon the data that we're collecting from around the country, our threshold for doing a CTA in someone who has been strangled is now just above the level of the floor. And we'll go through some of that information. So here is the finding from the radiologist, consistent with bilateral internal carotid artery dissection with an intimal flap on the left, and this was communicated to the emergency physician. So she was not discharged home. She was admitted to the ICU. She was anticoagulated and did very well. She was on anticoagulants for a total of 9 months. It did not require any stenting. And when we look at these carotid dissections, the vast majority of these are managed with anticoagulation therapy. A victim of strangulation, based upon our homicide data, is 750% more likely to be a victim of a homicide. This we call the final shot across the bow. If you have a victim, a patient who has a history of external pressure being applied to their neck, red flags, bells, sirens should be going off because she may be a homicide victim if we do not intervene. What is strangulation? From a medical perspective, it is the application of external pressure to the neck. And this can include the airflow, blood flow, or both, but the vast majority of the strangulations that I investigate or take care of are occlusion of the carotid arteries from external pressure. What signs and symptoms may an individual have? Well, more than half of fatal strangulations have zero external evidence of trauma. So if you can be fatally strangled and have no external evidence of trauma, how do we assess a strangulation victim? Well, I think the history is the most important, because if I have a patient that tells me I had visual changes, I lost consciousness, I lost control of my bladder, that tells me that they have had an anoxic insult to their brain. The presence of petechial hemorrhage because of increased pressure on the venous side of the system. Can we have fatal strangulation with no petechial hemorrhage? Absolutely. Can we have non-fatal with petechial hemorrhage? Absolutely. All the petechial hemorrhage says is there's been obstruction of the venous return and so much pressure that that blood that was coming through the arterial system had to go somewhere, and so vessels started to rupture. An important difference, when I've asked, and I take surveys, what is the difference between anoxia and hypoxia and brain death or death? The difference is when we block the carotids, we go from an O2 sat of in the 90s to 0. That's the anoxic insult, compared with a drowning, which is a hypoxic insult. Right? So here's our next question. What is the average time to render an adult male unconscious from the occlusion of the carotid arteries? Is it 6.8? Is it 10.8? 14.8? 18.8? Or we don't know, because no one has volunteered for that controlled study. .8, 10.8, 14.8, 18.8, or we don't know. Okay, and the answers are, Yeah, we're still calculating. Well, we're not there yet. Well, we have a tie for A and B. Well, the answer is, the answer is A, 6.8 seconds. And I will tell you, and I'll share with you the study of more than 500 controlled strangulations on volunteer inmates at the Red Wing Penitentiary, done under an NIH study back in 1944, where it showed that strangulation will induce loss of consciousness in an adult male in an average of 6.8 seconds. Very much quicker than, obviously, a lot of people thought. The lack of blood flow causes an anoxic brain injury. What is the brain's response to anoxia? Well, the very first thing is it stops functioning and you go unconscious. The brain cell damage begins in seconds, and here is, and I didn't put this on a test question, but if we block the carotids, when do we have death? When does the respiratory center in the medulla stop working? Again, do we have any controlled studies? Well, we do have 14 videotapes that have been reviewed by forensic pathologists and neuroanatomists. And they watched these individuals who either hung themselves intentionally or homicidal hangings, and it occurred between 62 seconds and 57 seconds. You stopped breathing. And there is an anoxic progression of what happens to the brain as you occlude blood flow. The first thing is you go unconscious. The next thing you have an anoxic seizure, convulsions that will last from 2 to 8 seconds. Then you lose control of your bladder. Then control of your bowel. Then you stop moving. And then you stop respirations. So we were told, 4 minutes to brain death. Well, that may be true in a hypoxia, in a drowning, but it is not true in an anoxic insult to the brain. This was the progression. 6.8 seconds unconscious, bladder at a minimum of 15 seconds. So when you're evaluating your patient, part of the history is, tell me what happened. Did you have visual changes? Did you lose control of your bladder? And they're not going to volunteer this because they're embarrassed. But that says they are certainly on their way to dying because it's been a minimum of 15 seconds of anoxia before they lose control of their bladder. 30 seconds, control their bowel. And is there a point of no return? Well, who's going to volunteer for that study? But we do know that death will occur, meaning the brainstem stops functioning somewhere between a minute and 2.5 minutes of the anoxic insult. This is the paper where the neuroanatomists and forensic pathologists watched what happened on these videotapes. And this is pure occlusion of the carotids from external pressure. Unconsciousness, anoxic convulsions, loss of muscle tone, and then your last respiration. Much quicker than you probably thought. This is the study done by the National Institutes of Health in 1944 by 2 physicians, one out of Bethesda, where they had more tthan 500 controlled strangulations. There were 11 schizophrenic patients. I don't think they could give informed consent. And 126 male inmates who would volunteer. Back then, if you volunteer for medical experimentation, the warden might commute your sentence. But this is the largest study of controlled strangulation anywhere ever done and written up. And obviously, you recognize, as the physicians did, that the neurons in the brain are the most sensitive to the lack of oxygen, the anoxic insult. This was the device. Applied compression pressure to the carotids bilaterally. They gave each subject a button. Said, you can stop this at any point you want to. Guess what? None of them were able to push that button to stop it. It happens so quickly. How many brain cells do we lose per second, or synapses per second, based on the stroke literature? And it's 32,000 neurons per second and 230 million neurons or synapses per second. That's a lot of brain cells. This isn't going to show up on the CAT scan or the MRI. In the future, we will have a blood test. Probably it'll be the S100B protein that will show that there is evidence of brain cell death. Just like we have CKs and troponins, we will have at some point in the future a blood test for brains.
Pittsburgh getting choked out right here. Yes.
It's going on MySpace. MySpace.
I've been wanting to see this for a while.
And he goes to sleep. Pittsburgh, you're going to die. And he's asleep right there.
Go ahead.
Oh, he's being serious.
Watch his seizure. That's the anoxic seizure. Yep. Do you think Pittsburgh had any memory of what happened? No. There are lots of videos, and YouTube is great for doing this kind of research. When you render someone unconscious and there's no blood flow to the hippocampus, they have no memory of what happened. Over and over again. They don't remember. There's a video that ESPN Sports did of someone who volunteered to be choked out using a rear naked choke. He was unconscious in about 8 seconds, and when he woke up, he said, "Did I get choked out?" He had no memory of it. So what are the symptoms of the anoxic insult to the brain? Well, the very first one is you go unconscious. The brain stops functioning. Visual changes, auditory changes. The patients may say they saw spots, things went black, a curtain came down. The memory issue, no blood flow, no memory, some neurologic impairment, and obviously seizure activity is evidence of that neurologic insult. How much pressure does it take to occlude the vessels in the neck or the trachea? Just 4 pounds of pressure to occlude venous return, 11 pounds of pressure to occlude the carotids. Trigger pull on a handgun, 5 or 6 pounds. To open a can of Coke, 20 pounds. And that's just with a single finger. When you apply pressure to the neck, that's the easiest way to kill somebody. It is much more effective than a gun because you're going to render them incapacitated in 6.8 seconds. So here's some examples. The average adult male handshake, 80 to 100 pounds. Some of my SWAT guys are up to 160 pounds. That's with one hand. So that's 10 times the amount of pressure required to kill somebody with just a single hand. Now what do you think if you've got 2 hands or you're mad? See how easy it is to render somebody unconscious. What are the complications of these anoxic insults? Well, we are finding that, and this is all anecdotal so far, and we're trying to establish a national database of strangulation so we can have more data, but there's not a whole lot out there, that women who are strangled are having cryptogenic strokes 10, 20 years later. Now, how many strangulation or how many stroke victims have we ever asked, were you strangled? We don't. Even in stroke centers, they don't ask, were you strangled? So we have these middle-aged women coming in with strokes, and they're not embolic, they're not thrombotic, they're not hypertensive strokes. It's because the areas that was died from that anoxic insult years earlier. These are 2 cases of women who presented to an emergency department at a level 1 trauma center, and they presented with a history of strangulation with loss of consciousness. They appeared fine, just like Tanika did, and they were both sent out without any sort of vascular visualization. They both stroked and died. Both had carotid artery dissections, looked fine. How was the pressure applied? One was they just had a hand on the neck. They had no external evidence of trauma, but they did have a history of being rendered unconscious. The other was in a carotid vascular neck restraint, forearm and bicep applied to the neck. And what's happening As the carotids, particularly the internal carotid, are compressed in the area of C2, C3, they're being pushed against the lateral processes of the cervical spine, and that's where they're getting these injuries. Here's one patient that I saw at my trauma center who had an intimal tear. This was a CT with contrast, which is not the ideal study, and we'll get to what is the best study. But she had an intimal tear. I mean, she did fine, but the resident recognized and remembered the lecture because she'd had that loss of consciousness. He ordered a CT of the neck and found that intimal tear. Did fine. There are some police departments across the country that are still training officers to use the carotid vascular neck restraint as a form to render someone unconscious. Well, I've got to tell you, this, in my agency, this is lethal force. It's just like drawing your gun. There was one officer that I took care of in a smaller agency who went through carotid vascular neck restraint training, was not rendered unconscious, tapped out before he went unconscious, and stroked 10 minutes later. And he wasn't the first police officer to stroke. There was one in Florida at the police academy who stroked again. Not rendered unconscious, but because as we age, we develop plaque in our carotids, plaque broke off, and he had an embolic stroke. And here's my police officer's MRI. The areas that are white are areas of infarct from the plaque breaking off when pressure is applied to the neck. Last month, the Training Institute on Strangulation Prevention and their medical advisory committee released a protocol to help emergency physicians. How do we evaluate patients who have present with a history of strangulation? One of the members on that committee was one of my mentors, the former chairman of emergency medicine here in Phoenix, Steve Szczepinski. He was on the national committee. He's done a lot of research into strangulation, and so this was adopted unanimously, and this protocol is available for you to download and distribute to your hospital. The question is, when do we need to do a CTA, which is the test of choice? We went back and looked at all 250 articles that we could find in the literature of strangulation, complications, brain injury, carotid dissections, and we came up with this list. Every symptom on this list had an associated CTA, or had a carotid injury that should require some sort of visualization. The CTA, the committee recommended as the gold standard. It is easily available in most emergency departments across the country. It's much easier to get than the MRI or MRA at 2 o'clock in the morning. So this is what we have said is the test of choice. Not only will it evaluate the carotids and vertebrals, but it will also look at the soft tissue of the neck. It'll evaluate the hyoid and the larynx and see if there's any additional fractures there. MRI is very good. Some studies say it's more sensitive, some say it's less sensitive than the CTA, but for the money and the ease of getting, we went with the CTA. Carotid Dopplers are good for the common carotid and external carotid, but it does not get the vertebrals or the internal carotid up toward the base of the brain. So CTA is the way you want to go. The protocol has recommendations of who can be discharged, who needs to be admitted. Obviously, if the CTA is positive, you're going to consult either neurosurgery, trauma, ENT, depending on what the issue is. If you have a negative CTA, they can go home, as long as there's good monitoring with an admonition that they need to return if symptoms become worse. So what I want you to remember is that strangulation victims may have no external visible injuries, only transient symptoms related to compression of the carotids, depriving the brain of oxygen. And these patients can die and stroke days later, even though they look like a rose in the emergency department. The carotid and the vertebrals, especially the internal carotids, must be evaluated if the patient has signs and symptoms related to the application of pressure, which this is the history. Did they have visual changes? Did they have loss of consciousness? Did they have loss of bowel or bladder? Something that says there's enough pressure to deprive the brain of oxygen, then there's enough pressure to cause an injury to the internal carotids. And that history of vascular compromise, again, loss of consciousness, visual changes, loss of bladder control, I think, is the key and is the most sensitive indicator. We can no longer look at the external neck and say, all right, time is up and we're right on schedule. We can no longer look at the neck looking for the presence of hemorrhage, bruises. If we have that, certainly we have an indication, but remember, you can be fatally strangled and no external evidence of trauma. The only difference between a fatal strangulation and non-fatal strangulation is the amount of time that pressure is applied to the carotids. Questions? So I hope this information, the protocol, will assist you and evaluate and help you change your practice of how we evaluate someone who comes in with a history of strangulation. Yes? You're still off. Hold on.
I'll just talk louder.
There we go.
We're on now.
All right.
Yeah. I'm Chris Myers. I'm a surgery resident, and I've been practicing Brazilian Jiu-Jitsu for like 16 years now. So I have a two-part question for you related to that. In all my training sessions, several states around the country, I've never seen anybody have any long-term injury from being rendered unconscious. Happened to me several times, done it to other people several times. So how can you account for that? I know it's just anecdotal, but with years of experience.
Well, if you'll review the literature, there are cases of judo instructors who have stroked and have brain injuries from that. I'll be happy to share those papers with you. In most jiu-jitsu, in martial arts, most people will tap out before they go unconscious. But there are cases of judo instructors, martial arts masters who have stroked and who have evidence of brain injury from anoxic insults.
And then my second part.
So you're very lucky. Stop doing it.
No way, never, no way. Do you think there's maybe a further area of research there? Then?
Absolutely. What the Institute is trying to do is create a national database of strangulation cases. What is the incidence of carotid artery injury? In my, it's between 1% and 2%. In my 200 cases, there's a database in Kansas where it's about 8% of carotid artery injuries with strangulation. So we don't know. We need a database. If you have cases, please send them to me, and we'll add them to the study and we'll write them up.
Roger that. Thank you.
Thank you. Great question.